Today's case discussion is on the topic of unmasking the hormone maze, navigating congenital adrenal hyperplasia. Today, Dr. Janani Santuresen, consultant pediatric endocrinologist from Serimo Bandaranayak Children's Hospital, is joining with us. So I must thank her for agreeing to join with us today for the discussion part to share her expertise knowledge on pediatric endocrinology. So I hand over the presentation to start to Dr. Tilini, and we will proceed, and then we will go ahead with the discussion part.
Thank you, madam. Case 1, classic salt-losing CAH with complications. 4-year, 7-month-old girl, second born to the consanguineous parents. She had a positive family history of salt-losing CAH in her elder brother. So, at birth, they have concern about clitoromegaly. Genital examination revealed partially fused pigmented labia majora with 1.5 centimeter clitoromegaly and no palpable gonads within the labial folds. There was a single perineal opening. According to the genital classification, it was Prader stage 3. Other than her general and systemic examination were unremarkable. With the positive family history and genital examination findings, she was kept under observation. On the day 4, she developed hyponatremia with features of mild dehydration. Her sodium level was 131 millimoles per liter, potassium levels within the reference limit. Her basal 17 OHP levels was elevated 37 nanomoles per liter, which is much more higher than the reference limit for newborn. And ultrasound scan pelvis revealed the presence of Mullerian structure that develops into female reproductive tract. Karyotype confirmed 46XX female. With the clinical and initial biochemical evidence, her diagnosis was concluded as classic salt-losing CAH. Without any delay, the treatment was started with appropriate and calculated regular dose of hydrocortisone and fludrocortisone. She was started on regular follow-up in endocrine clinic with monitoring of clinical features and biochemical investigations. Surgical follow-up also arranged due to common urogenital sinus. And she was suffering from urinary incontinence and recurrent UTI as well. She's awaiting for genitoplasty. She was on regular medications with hydrocortisone and fludrocortisone. Up to 4 years, it was continued and then omitted the fludrocortisone. Now she is on hydrocortisone and spironolactone. Even with regular medications, she is having worsening of clitoromegaly and advanced born age. Her 17 OHP levels were markedly elevated, more than 75.6 nanomoles per liter. And there is a gradual elevation in serum testosterone level up to 7.04 nanomoles per liter. FSH and LH were low normal values. This is her height chart. There is a increment in born age. Her chronological age was 4 years and 6 months. At that time, her born age was 6 years and 10 months. There is a height deviation from 3rd centile to 10th centile with the advancement of born age. These are the problems we have encountered. Poorly controlled CAH, increased hydrocortisone dose up to 15 milligrams per square meters per day, and timing of hydrocortisone was changed. Benefits of modified slow release hydrocortisone was there, but resource limitations limited the supply. hyperandrogenism. Anti-androgens for androgen receptor blocker, spironolactone was started. As aromatic inhibitor, letrozole started. Peripherally induced central precocious puberty. GnRH analog to stop central progression of puberty. Common urogenital sinus. Prader stage 3, correction of urogenital sinus, clitoroplasty and vaginoplasty is awaiting. Timing of surgeries depends. This is the case 2, poorly controlled classic salt-losing CAH. Elder sibling of case 1. A 12-year and 9-month-old boy who was diagnosed with salt-losing CAH at the age of 3 months with failure to thrive. At that time, started on hydrocortisone 8 to 10 milligrams per square meters per day, 4 times daily basis. But after that, he was defaulted clinic follow-up and later presented with progress to peripherally induced central precocious puberty. Then treated with GnRH analog at the age of 9 years, continued till 11 years. This is his investigation profile. There's a marked elevation of 17 OHP up to 339 nanomoles per liter, and marked elevation in testosterone as well, up to 20.5 nanomoles per liter. His LH within the normal range but low normal 1.29 international unit per liter. FSH is low 0.68 international unit per liter. His sodium and potassium levels were within reference limit. Ultrasound scan scrotum revealed right testis 9.3 milliliters, left testis 8 milliliters, which is much higher than this age. Bilateral testicular multiple small echogenic foci was noted, indicating microcalcifications distributing diffusely within the testis. No obvious testicular masses. Vascularity is slightly increased in both testes. Epididymis is normal. This is his height chart. In the chronological age of 9 years and 9 months, his born age was 13 years and 6 months. After that, repeat investigation at 12 years and 10 months of chronological age, his born age is 17 years. There is a marked height deviation from centiles. He is continued after the diagnosis with hydrocortisone appropriate dose and vitamin D 5,000 units per day. With the evidence of CAH, he was started on hydrocortisone, but there is a poor response. Then it's changed to oral dexamethasone short course. He's awaiting repeat ultrasound scan scrotum for microcalcifications. Plan to repeat 17 OHP and testosterone in 3 months' time. These are the problems encountered. Poorly controlled CAH. Short course of dexamethasone was started because he was not properly respond to hydrocortisone. Hyperandrogenism with metabolic complications and hypogonadotrophic hypogonadism. Reduction in final adult height. Ultimately, final adult height will be compromised due to early fusion of epiphyseal growth phase. In the future, fertility problems will occur related to testicular adrenal rest tumors, testicular microlithiasis, and hypogonadotrophic hypogonadism. Testicular adrenal rest tumors, seminiferous tubules obstruction leading to infertility. Untreated testicular adrenal rest tumors can lead to testicular microlithiasis and later risk of testicular malignancy. Hypogonadotrophic hypogonadism will lead to infertility.
Case 3 is on congenital adrenal hyperplasia with hypertension. The case is the patient is a 5.5 months old boy presented with acute gastroenteritis, and he has developed hyponatremia during the illness, and sodium level was 115 millimoles per liter. Even though the diarrhea was settled, after the subsequent monitoring, he was found to have persistently low serum sodium levels, uh, which was around 124 millimoles per liter. And here I want to mention about his family history, and his family history is significant for familial glucocorticoid resistance in her elder sister, and her serum cortisol level short synecton test is more than 2000 nanomoles per liter, and it was significantly high at that time. And we have had a query whether it was due to interference with adrenal steroid precursors. And also in her elder sister, she had virilization, and she has undergone surgical correction for that. And she had hypertension too. Now moving on to this particular patient's examination findings, he had growth faltering, and his blood pressure was normal at the presentation, and his genital examination revealed right inguinal hernia, right undescended testis, and left testis was palpable in the scrotum, and the phallus was normal. Initial investigation of the patient revealed normal testosterone level with a value of 0.44 nanomoles per liter, and random cortisol level was also normal, the value of 374. Serum ACTH was 14.6 picograms per milliliter. And his initial management was started, and he was given fludrocortisone and 3% sodium chloride. And later, with subsequent monitoring, he was found to have normal sodium levels. So, at the age of 1 year and 3 months, fludrocortisone and sodium chloride was omitted. Meanwhile, patient has had a period of defaulted treatment, and at the age of 3 years and 2 months, patient again presented to the endocrinology clinic with height acceleration, hyperactive behavior, and visualization features. On examination, he was found to have high blood pressure of 111 by 58 millimeters mercury, and it was more than 99 centile. And he also had a growth spurt, and he has masculinization, and genital examination revealed axillary hair stage 2, pubic hair stage 2, and genital stage was 2 to 3. And right testicular volume was 6 milliliters, and left testicular volume was 8 milliliters. Born age at that time was 8 years, although the chronological age was 3 years and 2 months. Investigations at the age of 3 years and 2 months revealed SST for cortisol, there was inadequate response, and testosterone was within the normal range with a value of 2.05 nanomoles per liter. Both FSH and LH were very low, and it showed the patient was in a hypogonadotrophic status. 17 OHP was very high with a value of 16.22 nanomoles per liter, and plasma aldosterone concentration and plasma renin concentration were both low, indicating a status of hyporeninemic hypoaldosteronism. 2D echo of the patient at that time revealed mild concentric LPH, and ultrasound scan of the testis showed testicular adrenal rest tumor with no testicular microlithiasis. Management at that time was with oral hydrocortisone, nifedipine for blood pressure control, and letrozole. On further follow-up, at the age of 3 years and 7 months, patient was found to have a low LH value of 0.33 international units per liter, and he was diagnosed to have peripherally induced central precocious puberty. And for that, he was started on GnRH analog. And now moving on to current situation of the patient. Now the patient is 4 years old, and clinically he has improved a lot with no increased pigmentation, no increased visualization, no height acceleration. And pubertal examination shows axillary hair stage 1, pubic hair stage 1, and genital stage 2 to 3, with bilateral testicular volumes of 4 milliliters. This indicates the patient has improved a lot with the continuous medications. And testosterone level also has reduced when compared to the level at the time of diagnosis, and it is less than 0.17 nanomoles per liter. And serum SCTH value is 16 picograms per milliliter. So, clinically and biochemically, patient has improved with continuous medications. At the moment, patient is on oral hydrocortisone, spironolactone, subcutaneous Soladex, and vitamin D with good compliance and frequent clinic follow-up.
Case 4, late onset non-classic CAH. A 13-year-old girl presented with ambiguous genitalia at 3.5 years of age. There was a progressive clitoral enlargement and clitoroplasty was done at 5.5 years of age. She had precocious puberty at 7 years of age with standard staging of breast size of stage 2, pubic hair stage 2, and bone age of 10 years. She gives a history of spotting at 12 years of age that was suggestive of menarche. Hereafter, no menstrual periods. She had hirsutism, but no pigmentation or no salt craving episodes. On examination, she had hirsutism involving independent facial hair on chest and abdomen. Her height was 140 centimeters, which was static for the last few years. She had normal blood pressure value of 97 by 59 millimeter mercury. Overall puberty staging was standard stage 3 with axillary hair stage 3, puberty hair stage 3, and breast stage 3. On investigations, her serum electrolytes levels were normal throughout the follow-up, and LH-FSH levels were within the normal reference range but low normal. She had high level of testosterone of 1.21 nanomoles per liter and very high level of 17 OHP with more than 90 nanomoles per liter. The serum progesterone level was also high with 5.8 nanomoles per liter. We have done ACTH on this patient and that was within the normal reference range. She was started on oral hydrocortisone, and after the treatments we have repeated the hormone profile, and there we saw that there's a marked reduction of testosterone of 0.12 nanomoles per liter. Her ultrasound abdomen at 12 years showed that there was a uterus with endometrial thickness of 3 millimeters, and right ovary there were few small follicles. Case 5, classic simple virilizing CAH with cortisol as an interference. A 5-year-old baby girl presented with ambiguous genitalia. Her feeding was good with normal urine output and bowel opening. There was no maternal history of virilization and her prenatal history was uneventful. No electrolyte imbalance at the age of day 5. On examination, the child was in good hydration and normal tone. There was a cardiac murmur, which was a systolic murmur. No midline abnormalities, but the child is dark in complexion. The blood pressure was normal with 80 by 55 millimeter mercury. On genital examination, there were pigmented rugae labial folds, but no palpable gonads in the labial folds. There was a phallus-like structure with 3 centimeter length and 0.5 centimeter width. There was a single perineal opening which was common to both vagina and urethra. According to the genital classification, the child is at Prader stage 3. On investigations, serum electrolyte levels were within normal reference range. And here we have detected a very high level of stimulated 17 OHP level with 109 nanomoles per liter. And for the SST cortisol, baseline level was 406 nanomoles per liter and 60-minute level was 1608 nanomoles per liter. Here we expected a low cortisol level, but even for the baseline value, we got a high value of 206. She is awaiting ACTH. Her ultrasound pelvis showed uterus with fallopian tubes and bilateral ovaries. We have done karyotyping in this patient and got 46XX, which confirmed her female gender. The 2D echo showed a large AP window and the baby was awaiting surgical correction. At the end, these are the problems we have identified in this child. She is clinically having classic CAH with clinical evidence of virilization started stage 3 and single perineal opening. And biochemical evidence is there was the elevated stimulated 17 OHP level. And for the standard dose SST, we have got a normal cortisol response. Even we expected a low cortisol level. So there may be a cortisol assay interference with adrenal steroid precursors. On management, we have started oral hydrocortisone in this patient and plan to add hydrocortisone if sodium levels are low.
Now we have presented 5 cases of different presentation of CH. So to start with the discussion, I invite Dr. Chandni to start.
Thank you for giving me the opportunity. Can you all hear me?
Yes.
Okay, yeah.
Can you move the slides?
I can't move the slide. Yeah.
Wait, we'll try. We'll stop. Now, can you check?
Okay. Still not. That is okay. If you can move the slide, I will speak on it.
Yep.
Okay.
Now try. Is it possible? No? Not moving?
No, not moving.
Okay, we'll move. Okay.
Okay, yeah, sure. Thank you. So we'll go through the CAH introduction. CAH is a genetically determined disorders of defective adrenal steroidogenesis, so which result in deficiency of adrenal steroid end products such as cortisol and aldosterone, and rarely in few cases you have sex hormone deficiency as well. Severity of the CAH vary depending on the variability of the genetic alterations. And there is an accumulation of adrenal steroid androgens, which causes virilization, especially in the female children. Next slide. Next, please. When we come to epidemiology, there's a worldwide prevalence of classic CAH is 1 in 15,000. The commonest one is 21 alpha hydroxylase deficiency, which is more than the 90%, roughly around 95%. The second most commonest is 11 beta hydroxylase deficiency, which account for less than 5% of the cases. Non-classic CAH prevalence is 1 in 100,000. Unfortunately, at the moment, we don't have prevalence in Sri Lanka. Next, please. When we come to the pathophysiology, clinical features and biochemical parameters vary with the type of deficit enzyme and also the degree of enzyme deficiency. The measurement of the precursor steroid in the blood as well as the urine will help to identify the specific enzyme defect and monitor the response to the replacement therapy. Next slide, please. As I have mentioned, the commonest one is 21 alpha hydroxylase deficiency, which is divided into two categories. One is classic CAH, then the other one is non-classic CAH. Classic CAH can be divided into salt-wasting CAH and also simple virilizing CAH. Less than 5% of the CAH cases are contributed by mainly other 5 enzyme deficiencies. The number one is cytochrome P450 side chain cleavage enzyme. And the other one is steroidogenesis acute regulatory protein mutation, which will cause lipoid congenital adrenal hyperplasia. The other one is 17 alpha hydroxylase deficiency, 3 beta dehydrogenase deficiency, and also 11 beta hydroxylase deficiency. Next slide, please. When we come to the commonest form of 21 alpha hydroxylase deficiency, it is caused by the mutation CYP21A2 gene mutation, which is located in the chromosome 6. It is characterized by the reduced production of cortisol and aldosterone, and it is increased sex steroids. When there is a block with 21 alpha hydroxylase deficiency, there is increased production of 17-hydroxyprogesterone, and then it is converted to adrenal sex steroid, and these sex steroids can cause virilization in female. The clinical presentation vary with the degree of enzyme deficiency, as I mentioned previously, classic salt wasting, classic simple virilizing, and non-classic form. Next slide, please. The clinical presentation is hugely varied. When you come to classic CAH, the female children, due to virilization, they are identified very early during the neonatal period. But unfortunately, the male children, external genitalia looked normal, except for some hyperpigmentation and increased rugosity. These children will usually present around 10 to 14 days with severe Addisonian crisis. Sometimes this presentation can be delayed and they present later on with severe failure to thrive and hyponatremia. Non-classic CAH, they can present at any time from childhood to adult. So when you come to the enzyme activity of 21 alpha hydroxylase CAH, you don't have any activity in classic salt wasting CAH. Around 1 to 2% activity is detected in classic simple virilizing form, and around 20 to 50% of enzyme activity is there in the non-classic form. And all these CAH 21 alpha hydroxylase, they don't have any hypertension. Next slide, please. Cortisol deficiency will cause malaise, failure to thrive, hypoglycemia, and vascular instability. Aldosterone deficiency will lead to hyponatremia, hyperkalemic metabolic acidosis, dehydration, and hypotension. The most severe form of salt-losing CAH with 21-hydroxylase deficiency and some other rare forms such as 3-beta-hydroxysteroid dehydrogenase deficiency with complete enzyme block, they usually present between 10 to 14 days with Addisonian crisis. If it is untreated, mortality is very high in salt-losing CAH. The non-salt-losing form of this disease is customarily referred as a simple virilizing form of CAH. Next slide, please. There is a varying degree of virilization, and we have a Prader stage classification to stage the virilization. So there are around 1 to 5 stage. 1 and 2 Prader stage is usually a milder form. 4 and 5 are more severe form, and stage 3 is an intermediate form. In Prader stage 1, you have only clitoral hypertrophy. In Prader stage 2, you have clitoral hypertrophy. There is separate urethral and vaginal orifice, but the distance between both orifices is very less. In type 3, there is clitoral hypertrophy and there is single urogenital orifice and there is posterior fusion of labia majora. In type 4, there is penile clitoris, perineoscrotal hypospadias, and there is complete fusion of the labia majora without any palpable gonads. Type 5 Prader stage is like complete male-looking genitalia, completely masculinization, but there is no palpable testis. Next, please. This is a CAH female who is untreated. You can see the masculine body habitus and there is hirsutism, especially in the androgen-dependent area. And she had an accelerated growth. And after some time, the growth was static. And you can appreciate there is no much breast development because elevated androgen can suppress the gonadal axis and you won't produce my estrogens. So similarly, in female patient also, it can happen. They can have accelerated growth and early epiphyseal closure can lead to ultimate short stature and they can have hyperactive behaviors. So need a good control of CAH to prevent all these complications. In late onset non-classic CAH, mainly you can see in the female presenting with hirsutism, virilization, menstrual irregularities, either amenorrhea or oligomenorrhea, polycystic ovarian-like syndrome, and sometimes subfertility or infertility. These patients, baseline 17 OHP can be normal, but their stimulated 17 OHP is more than 30 nanomole per liter. Next, please. Eleven beta hydroxylase deficiency is the second most commonest type of CAH. It is due to CYP11B1 mutation. So when you have a CYP, like 11 beta hydroxylase deficiency, can you all see the pointer? Okay, yeah. So when you have 11 beta hydroxylase deficiency, there is an accumulation, there is a deficiency of cortisol as well as androsterone. But above the block, you have elevated developed 11-deoxycortisol and 11-deoxycorticosterone. So 11-deoxycorticosterone act on the mineralocorticoid receptor and this will lead to volume expansion, hypertension, and this will reduce renin and causes hypokalemia. Generally, you will be having a slightly elevated 17 OHP and the female patient can have virilization. So these patients usually presented with cortisol deficiency, hypertension, virilization, especially in female. Male, they have cortisol deficiency and hypertension. Next slide, please. The other rare form of CAH, 17-alpha hydroxylase deficiency, it is due to P450C17 gene mutation. Actually, this gene is responsible for two enzymes. One is 17-alpha hydroxylase and other one is 1720 lyase. Basically, 17-alpha hydroxylase is mainly in zona glomerulosa and zona fasciculata. 1720 lyase activity is mainly in zona reticularis and in the gonadal tissues. So if you have a complete 17-alpha hydroxylase activity, you don't have cortisol production as well as sex steroid production such as testosterone and estradiol. But there is an intact mineralocorticoid active pathway and there is increased deoxycorticosterone as well as corticosterone. So this can cause to hypertension. The corticosterone can have some activity of glucocorticoid. So most of the time, these children will not have symptoms related to hypocortisolism. So when you see a patient with 17 alpha hydroxylase complete deficiency, like if it is a male patient with 46XY, because of the lack of sex steroid production, the external genitalia look like complete female. But if there is a partial deficiency, of course, you can have an ambiguous genitalia with hypertension and cortisol deficiency. In view of female 46XX, because a lack of sex steroid estradiol production, they will not progress through the puberty and they won't have secondary sexual characteristic. Next slide, please. Other rare form of CAH, 3-beta hydroxysteroid dehydrogenase deficiency, but in Sri Lanka, we commonly see this patient may be due to genetic variation. So here, the enzyme block will cause all three hormonal deficiency, aldosterone, cortisol, as well as sex steroids. So male with 3-beta hydroxysteroid dehydrogenase deficiency, they will have aldosterone cortisol deficiency, and due to lack of testosterone, they have undervirilized external genitalia. Female, because of the block, there is an elevation of DHEA and DHEAs, and that can convert some adrenal androgens. So in female, you can have adrenal crisis with like salt losing and also virilization features. Next slide, please. So this is a summary of enzyme deficiency in CAH. So I'm going to quickly summarize what I have told you now. So 21 hydroxylase deficiency, usually the classic form will usually present between 2 to 3 weeks of age. And they have elevated 17-OHP, they have elevated androstenedione. Due to lack of aldosterone, the renin is high and the potassium will be high. They have reduced cortisol and aldosterone. Usual presentation is adrenal crisis, dehydration, hypoglycemia with hyperkalemia and hyponatremia. It can be fatal if not treated promptly. So 46XX patients will have ambiguous genitalia. Excess androgen can cause early puberty and also early skeletal maturation, and ultimately they can have short stature. When you have a non-classic CAH, enzymatic activity is up to around 20 to 50%, and the female can present with hirsutism, menstrual irregularity, infertility, and polycystic ovarian syndrome-like picture. The second most common is 11-beta hydroxylase deficiency. So they have elevated 11-deoxycortisol and deoxycorticosterone. They can have mildly elevated 17-OHP. There is cortisol and aldosterone deficiency. Because of the mineralocorticoid precursors, they have suppressed renin and hypokalemia. They will be having hypertension, and 46XX female are virilized. 17-alpha hydroxylase deficiency, if it is a complete enzyme deficiency, they can have like 46XY. They will have a female looking external genitalia. In 46XX, there's an absent puberty and there is no secondary sexual characteristic. But if it is a partial enzyme deficiency, they can have ambiguous genitalia. They can have elevated deoxycorticosterone and corticosterone. There is suppressed cortisol and aldosterone. There is reduced cortisol level. Due to increased deoxycorticosterone, renin is suppressed and they will have hypokalemia. 3-beta hydroxysteroid dehydrogenase deficiency, the DHEA and DHEAs are very high. You can have high renin activity. Infant can present, if the complete enzyme deficiency, infant can present during the neonatal period with adrenal crisis. 46XY male will have a undervirilized external genitalia due to underproduction of testosterone, and 46XX female can have virilization due to overproduction of adrenal sex steroids via the alternative pathways. Next slide, please. I will hand it over to Dr. Dulani to continue with the investigations.
Yeah, thank you, Dr. Chanani. And now we will move into the investigation, and Dr. Chanani has summarized what are the investigations that we should do depending on the clinical presentation and different diagnoses in the acute stage and during the follow-up. Investigations, the routine biochemical investigations, we have to do, depending on the patient clinical presentation, we have to assess the electrolytes and the blood glucose levels. And for the specific diagnosis, we have to do special investigation like 17-OHP, basal levels, and if we want to confirm the diagnosis, depending on the presentation, we have to do the stimulation test and the cortisol, also basal level and stimulation, and DHEAs, testosterone and aldosterone. The important thing is, because they are steroid hormones, usually we do the competitive immunoassay. And for the ACTH and renin, we have to do, which are the non-competitive immunoassays. Sometimes we might have to do the renin aldosterone, and basically we want the renin activity. And we want to confirm the karyotype, and the, as explained earlier, ultrasound scan pelvis to identify the Mullerian structures and gonads, ovaries and testes. Then sometimes we might have to proceed with urinary steroid profile, urinary free cortisol, 20-hour urine collection. And finally, to confirm the diagnosis, we need genetic studies to confirm our differential diagnosis. And a little bit about the standard dose synactin test. What we initially do is we do the basal serum cortisol level, or if we are going to stimulate the 17-OHP, we have to do the basal level 17-OHP. Then we give the IV synactin. The vial contains 250 microgram. If we are going to do with the neonate, we have to adjust to the body weight and specific amount for the body weight we have to give. Ideally, if it is less than 2 years, 125. If it's more than 2 years, we can give 250, and for the adults, also the 250. Then after giving the synactin, we have to collect the samples at 30 minutes and 60 minutes for the cortisol and 17-OHP. And in one case reports, you might have noticed that we have done only 60 minutes because of the limited resources that we have. And usually there is no difference between, if there is no significant difference between 60 and 30 minutes and 60 minutes, we can go with the 60 minutes. Okay, then regarding the 17-OHP and cortisol measurement, here first with the clinical presentation, we can suspect what we are going to do with further investigation. And 17-OHP levels are normally high at birth and decreases rapidly during the first few days after in a healthy infant. And 17-OHP level increases with time if the patient is affected with CAH. But premature and sick babies, stressed babies with sepsis, can have higher levels of 17-OHP than the term infants. And so with proceeding with the investigations, first we have to do the morning 9 17-OHP. So if it is less than 6 nanomoles per liter, we can exclude 20 OHD deficiency. But if it is in between 6 and 30 nanomoles per liter, then we have to proceed with the ACTH stimulation test. So if after the stimulation, if it is less than 30, then again we can exclude 21 hydroxylase deficiency. And if it is more than 30, it confirms that 21 hydroxylase deficiency is there. So for the cortisol, if the cortisol response after 60 minutes is more than 450 or 500, there are differences in different platforms, the cutoff givens. And so depending on that, we can do the interpretation. It indicates the adequate response to SST. And 17-OHP, if it is more than 30, diagnostic of CH. So regarding the 17-OHP measurement, usually practically available ones are in our practice is immunoassay. So if blood is taken from the newborn infant in the first days of life, we can use the GCMS, LCMS, we can use it to detect. But in immunoassay method, sampling should be ideally done at second or third day because placental steroid and maternal 17-OHP is present in baby's blood and it can interfere with our assay, and so there can be a misinterpretation of results. And classic CH basal and stimulated 17-OHP is high if we do it, and normal 17-OHP does not exclude the non-classic CH, and ACTH stimulation test is required to detect non-classic CH. The other thing that we encountered during the follow-up of the patient who was referred from the endocrinologic, there was some suspected results with cross-reactivity of steroid hormones because there is a metabolic blocks of cortisol biosynthetic pathway that you during the discussion, Dr. Janani explained how it happens. There is accumulation of various precursors, especially immediate precursors. And if you go for the chemical structure of these molecules, they have a similarity of their molecular structures. Because in our immunoassay, our target molecule or the epitope that the antibody is developed, there can be a cross-reactivity in these immunoassay. Other thing is because our steroid immunoassay is the competitive immunoassay, and there is only one binding site is available, and precursors with high degree similarity to the target hormone are more prone to do the cross-reactivity. So this is the diagrammatic explanation of the competitive immunoassay. I think the chemical pathology trainees are more familiar with this one. So there we detect the antigen in the serum sample, and we have the coated antibody. And in our reagent, we have the tagged antigen with the label. And in the competitive immunoassay, we allow both serum and the reagent to put together, and there is a competition for the binding. So if the molecule with similar to our detecting hormone, they also participate in the reaction and they go and occupy the antibodies because they bind. So they act as a same molecules that we are going to detect. So there will be a change in the signal. So it will indicate high concentration of that hormone. So this is again to explain what will happen, to remind you the pathway. So you can see there are a lot of precursors here. So depending on the enzyme deficiency, various precursors will accumulate. And I think you better go for the chemical structure of these molecules, then you will better understand how their structural similarities are there. And this is the theoretical reason for the explanation for an interference in these assays. So this is a reference from an article that gives the cortisol immunoassay cross-reactivity, and it indicates that that different compounds, that possible interferences, like if the patient is given cortisol, it is 100% interferences, and this article is about the Roche assay, but I think most of the assays have similar cross-reactivities. Here we have highlighted that 21-deoxycortisol. It says there is a 45% cross-reactivity unless except in patients with 21-hydroxylase deficiency. So if the patient has 21-hydroxylase deficiency, definitely there will be interferences. Like that, there are other compounds such as 11-deoxycortisol, 17-hydroxyprogesterone, and androstenedione. There are a percentage of reactivity is given there. So in our patient that we encountered some high level of cortisol, even though we expected it to be low, and it explained this that patient has got 21-hydroxylase deficiency, and there is accumulation of 17-hydroxyprogesterone, and with the enzyme 11-beta-hydroxylase, it will convert it to 21-deoxycortisol. So that 21-deoxycortisol has a structural similarity to cortisol, so it will interfere with the cortisol assay, giving the falsely high cortisol level in these patients. So that's the explanation for the falsely high level in our patient, that we detected high cortisol level. So cross-reactivity will affect all the steroid hormone. There is a possibility of interferences, and so we have to always interpretation should be done with relevant clinical history and previous available investigation, and together with the other investigation results, and also with the possible drugs that given in the previous phases. So always history and the pre-analytical phase, we have to pay our attention for the interpretation about the cross-reactivity. So this is the reference articles that we found regarding the cross-reactivity. So the other possibility, if you are suspecting interferences in the immunoassay, we can go with the alternative method. So the chromatography is the recommended method. So either alone or in combination with mass spectrometry. And LC-MS provides a high degree of specificity for steroid hormone measurements. But however, the chromatography and mass spectrometry requires special technical skills and high cost in the installation. Therefore, it's not freely available, and in current situation in Sri Lanka, it's not available for the hormone assay. So I will hand over to Dr. Janani for the management aspect to discuss with.
Can you hear me? Sorry.
Yes, madam.
Okay. I think now I can control with the okay. Coming back to the can you all hear me?
Yes.
Coming back to the management, when we consider the management of CAH, basically the CAH management is medical management. But if you have patient with virilization, especially the female patient, then you need surgical input as well. So medical management, we have to give a high doses of hydrocortisone, supraphysiological doses of hydrocortisone to suppress the ACTH to control adequately the CAH. So usually the hydrocortisone dose is 10 to 15 milligram per meter square per day, which is given 3 or 4 times daily. The flutorocortisone, the dosing is also very important to have a near normal physiological cortisol level in the blood. So we have to give a high dose in the morning, and it should be given as early as possible in the morning. And towards the evening, the dose is less, and you have to give as late as possible. The flutorocortisone dose is 50 to 200 microgram per day. It can be given 1 or 2 times daily. And neonates and the infants need sodium chloride supplementation to overcome the hyponatremia. It is usually 2 to 4 millimoles per kg per day. It is given as 4 or 5 times daily. When the growth is completed, then you can convert the hydrocortisone to prednisolone, which is given twice daily. And also, sometimes if you want, you can give dexamethasone once daily. The flutorocortisone dose is titrated depending on the blood pressure as well as renin activity. And when the child started to take sodium containing like normal weaning food, then sodium supplementation can be reduced and it can be stopped. So there are several complications related to patient with CAH. One is due to excess cortisol and other one is due to excess androgen. As we are giving supraphysiological doses of glucocorticoid, they are more prone to get osteoporosis, obesity, and they have more visceral fat and insulin resistant, and they also can be short stature, and there are a lot of other psychological effects as well. And due to the disease process anyway, if you are not adequately controlling, there is a high androgen levels. So if there is a high androgen level, there can be an abnormal and early puberty. Early puberty can cause acceleration of bone, and a early fusion of epiphyseal plate cause ultimate short stature. They also can have hirsutism, amenorrhea or oligomenorrhea, infertility or subfertility problem as well. Due to high ACTH, they can have nodular hyperplasia and tumors in the adrenal. And this uncontrolled elevated ACTH can cause testicular adrenal rest tumors, which can obstruct the seminiferous tubules and cause fertility issues later on. And female with CAH who are having common urogenital sinus and clitoromegaly, they will have to go for the corrective surgery, clitoroplasty and vaginoplasty. These patients also will have problem with the quality of life and also problem during with their sexual life, and also they can have problem with orgasm as well. As CAH, we need higher amount of cortisol and higher androgens levels in the body, which can cause which can cause cardiovascular problems and also can lead to metabolic syndromes. So there are three main pathways involved in the androgen synthesis in CAH patient with 21-hydroxylase deficiency. As we all know, as we all know, 21-alpha hydroxylase deficiency lead to accumulation of 17-hydroxyprogesterone. This higher amount of hydroxyprogesterone by the classic pathway and the enzyme 17-alpha hydroxylase, it can produce high androstenedione. Androstenedione, which will, by the classic pathway, which will cause increased production of testosterone. So this is one method where you get higher androgens level. The higher amount of androstenedione under 11-oxyandrogen pathway also produce 11-ketotestosterone, which is also a more potent androgen. The elevated level of 17-OHP progesterone will go via the backdoor pathway and they produce dihydrotestosterone. Dihydrotestosterone is a more potent testosterone than more potent androgen than testosterone. So basically, the testosterone, 11-ketotestosterone, and dihydrotestosterone act on the androgen receptors and exert the effect of hyperandrogenism. So during follow-up, monitoring of 17-OHP progesterone, androstenedione, testosterone, and 11-ketotestosterone, it is very essential to see the control of CAH and also to adjust the dose accordingly. So as I have said, during follow-up, we need to have the biomarkers 17-OHP, androstenedione, ketotestosterone, and testosterone. And especially when we consider 3-beta hydroxydehydrogenase deficiency, DHEA or DHEAS would help as a biomarker. And LHFSH is very important because high level of androgen can cause bone age advancement. Advancement of bone age can trigger the peripherally induced central precocious puberty. So when the LH goes beyond 0.3 units per liter, that indicate there is activation of central puberty. Annual bone age assessment is very important to decide the CAH control, and also if the bone age is advancing, then we have to tightly titrate the doses to have an appropriate CAH control. Plasma renin activity monitoring is very important to titrate the flutacortisone dose. And also sometimes there are rare form of CAH with hypertension. So to titrate the antihypertensives, plasma renin activity is also important. Serial ultrasound scrotum to look for testicular adrenal rest tumor is important. The recommendation is to do ultrasound after 10 years. But if you have a higher suspicious and the CAH is not under control, then the early ultrasound test is the scrotum is advised. Are we going to treat non-classic CAH? The answer is no. But you should have a lower threshold to start hydrocortisone if there is a progressive virilization, height acceleration, hyperandrogenism symptoms, amenorrhea or oligomenorrhea, subfertility or infertility. As we have discussed, there is a high cardiovascular risk due to disease and treatment for the patient with CAH. They are more prone to get metabolic syndrome. They are having high visceral fat and also hyperandrogenism. All contribute for the high cardiovascular risk. So healthy lifestyle modification should be initiated from the early childhood. You can see the cortisol circadian rhythm. So usually the cortisol started to rise between 3 to 4 a.m. and it have a peak cortisol level between 8 to 9 a.m. and started to slow down, and you will have a nida around the midnight. So what is happening if we are treating the patient with conventional 3 times daily hydrocortisone, you have abnormal high values and abnormal low values, and there is no cortisol in the blood in the night. So this can cause increased ACTH secretion and androgen production, and this will cause all the complications related to CAH. So modified release hydrocortisone, FMOD, have been approved by the FDA as well as European Medicinal Agency for children with CAH about 12 years. This is given twice daily. So first dose is given between 10 to 11 p.m. and the absorption occur around 3 to 4 a.m. And then the second dose is given at around 7 a.m. And the absorption is after that absorption will be afternoon. So you can see the normal circadian rhythm is matching with the modified release hydrocortisone regime. The clinical trials have been shown the great benefit. They have shown that 17-OHP and androstenedione, when you compare to basal level, the modified release hydrocortisone has significantly reduced the 17-OHP and androstenedione. And they have compared the 17-OHP and androstenedione with the standard dose treatment, and they have proven that there is a significant difference between the 17-OHP and androstenedione levels with modified release hydrocortisone treatment. So there are new pharmacotherapies for congenital adrenal hyperplasia which target different levels of hypothalamo-pituitary adrenal axis. There are preclinical and clinical studies in newer medication for CAH in future. So there are few, I have mentioned few. So corticotrophin releasing hormone receptor antagonists which block the CRH receptor. And there are anti-ACTH monoclonal antibodies which competitively inhibit with ACTH. And also there are ACTH receptor antagonists which block the ACTH receptor. And there are gene-based therapies and cell-based therapies which are newer therapies for upcoming CAH treatment. In view of cortisol deficiency, currently we are using hydrocortisone tablet 3 or 4 times daily. There are hydrocortisone granules, which is called Alkindry. There are smaller doses, so it is very convenient for the children. And now modified release hydrocortisone is available to mimic the normal circadian rhythm of cortisol. And also hydrocortisone pumps can be used for very poorly controlled CAH children. And there are androgen receptor antagonists such as spironolactone we can use to alleviate the hyperandrogenism syndrome. So in summary, CAH is an autosomal recessive heterogeneous condition. Need thorough biochemical evaluation before the diagnosis. Need close monitoring with biochemical markers, bone age, and growth monitoring to adequately control the CAH and to prevent complication. Non-classic CAH not warrant treatment always. However, low threshold to start hydrocortisone if developing complication during follow-up. Liquid chromatography and mass spectrometry provides a higher degree of specificity for steroid hormone measurement in suspicious patients with steroidal hormonal assay interference. Timing and dosing of hydrocortisone is important to achieve near normal physiological cortisol level in the body. Modified release hydrocortisone will be beneficial to our patient to prevent CAH-related complication. Thank you.
Now the forum is open for the questions. you have questions, because we have almost 1 hour is finished, but still we can encounter new questions.
So in that case of cross-reactivity, how was it proven that it was the high values were due to cross-reactivity, and what are in our setup, what can we avoid, what can be done to avoid cross-reactivity in our setup, like we don't have MS or HPLC, that we usually stop hydrocortisone, but in fludrocortisone and other drugs, if, what can we do, madam?
Actually, it's the interferences with the precursors. So, depending on the clinical presentation, with the discussion with the clinicians, we can discuss what are the drugs we can omit before the sampling. Then, if we are suspecting the interferences, only thing that we can do in different assays and check, but still, if there is high value, actually we don't have alternation. The literature, what literature mentioned is the LCMS to identify specific molecule, only we have to go for the LCMS. So in the absence of any more questions, and because we are running out of time, and if there are any questions, you can send to me or to the college, so then we can discuss with the Dr. Janani regarding the clinical aspect. And if you have any query, please send. And I invite Dr. Dilanti to deal with the vote of thanks.
Thank you, Dr. Dulani. I hope that you all can hear me.
Yes.
Can you all hear me?
Yes.
Okay. Thank you, Dr. Dulani. So we have come to the end of this productive case discussion session. So first of all, let me thank Dr. Janani Sundarasesan, consultant pediatric endocrinologist, Sirimau Bandaranayake Specialized Children's Hospital, and Dr. Dulani Jayawardena, consultant chemical pathologist, National Hospital Kandy, for their tremendous contribution in conducting this discussion and guiding the postgraduate trainees to present this excellent presentation and discussion. So thank you very much for your contribution amidst your busy schedule. And next, I would like to thank the chemical pathology postgraduate trainees, Dr. Tilini Premadasa, Dr. Hashini Jayasinghe, and Dr. Irunika Hera for their excellent contribution and presentation. And finally, I would like to thank all the participants who joined with us and encouraging us to conduct this session. So we hope to meet you in a similar case discussion next time. Until then, I would like to conclude the session and thank you for joining with us. Thank you.
Thank you.
Thank you all. Thank you for the contributions. Thank you.